so that we can reflect on the mysteries of life and death. Please help us to learn more about what to do in those times when there's serious illness. Please help us to follow your directives as we look at our human directives tonight. We ask your blessing on our ears so that we can hear what is said, and on our brains so we can remember what is said. We just thank you for being with us. We ask your blessing in the name of the Father, and the Son, and the Holy Spirit. Amen.
Thank you, Father. So just some brief introductions for our panel members. And you just saw Father Dane. He's our pastor here going on 3 years. Seminary education at St. Mary's Seminary at the University of Baltimore. He began his priestly duties at St. Pius in Mobile, and he had several assignments from the Archdiocese at that point in time, including the chaplain for St. Michael's Catholic High School, which I'm sure that was fun, and priest for the St. Benedict's Catholic School. Most of you know he's an avid golfer, so if any of you like to play golf, he'll take you out there and show you how to win tournaments, right, Father? So, thank you.
Not anymore.
Our second panelist is Mr. Ernest Hornsby. Most of you know him as Arnie, that are parishioners, and he's a lifelong Catholic. He was born in Dothan, raised in Dothan, and raised in St. Columba Church. He was an altar boy. He served many roles within the St. Columba. He was part of the dedication for the new church, which is now known as the chapel. So that was a long time ago. And so he went to Dothan High, University of Alabama School of Law, began practice in Dothan with his law firm, which is Farmer Price law firm here in Dothan. And he's been in practice since 1973 after serving in the Army. He continues practice in Dothan from then to this date. A large part of his practice includes probate matters, and he was kind of interesting. He had several honors and awards, and I won't get into all that for him, but he was very active in local and state and national bar associations. He was the past president of the Houston County Bar Association years past. He's married to his wife, Mary Ann, right over here, and they've been married 53 years. Congratulations. And she's a retired public school teacher after 45 years of teaching in elementary school. They have 3 daughters and 7 grandchildren. So he'll be our attorney expert. And our doctor speaker tonight is Dr. Christy Johnson-Pick. She and her husband her husband is Fred Pick. He's an ER physician here in Dothan. And I think he grew up here in Dothan, is that right, Christy? And so they both went to college and medical school in West Virginia. She left Virginia, went to Gainesville, and did her internal medicine residency at Shands. And then she's also certified at the UAB Clinical Training Academic Program in Palliative Care Medicine a few years ago, and she helped develop and was the director of the palliative care unit at Southeast Health. And currently she is the associate program director for Graduate Medicine Education Department, the Internal Medicine Residency. She has had multiple speaking engagements, including the UAB Palliative Care Summit a few years ago, and she's very knowledgeable on the topic at hand, and we're lucky to have her come and share her wealth of knowledge, and she's very well qualified to discuss the important topic. And I hope that you can spread this to your family and friends after you leave here tonight, so that they'll also know about what we're going to talk about. So we're going to move along, and we'll turn it over to Christy to let her speak. Thank you, Christy, for being here.
I'm honored to be here, actually. Thank you, Dr. Fillmore, for inviting me, and Father Jim. Thank you all so much. I would love for this to just be pretty informal. So if you have questions as I go along, feel free to just shout out at me, raise your hand, or wave to me, tell me to stop or slow down. There'll be plenty of time for questions afterwards, and Mr. Hornsby is going to hopefully comment too on the gaps that he can fill in as far as legal matters that I left out in here. So yes, I'm from West Virginia. My husband was born and raised here in Dothan. His family goes way back here in Dothan, and he was born at Southeast Health. And so we both went to school at West Virginia, like Dr. Fillmore said, and I've been down here now for about 13 years and have fallen in love with the South. I'm a Southern transplant, I like to say, so I don't foresee myself moving back to the North anytime. But I've thoroughly enjoyed working at Southeast Health. I've worked at Southeast Health since 2010. I started out as a hospitalist. And then for about 2 years, we made plans to start a palliative care program. We were actually the first palliative care program in the entire Wiregrass area. The next closest program is in Montgomery and then in Pensacola. So that program is still running. We started that program in 2014. I worked with the program until 2019, and then I did work for 2 years at the HIV clinic in town, formerly MAO, now Five Horizons, and I've been back at Medical Center for the past couple years. I've still stayed connected with the palliative care program. It's very close to my heart for multiple reasons. I've not only had extra training in palliative care, I'm an internal medicine physician by training, but I had extra palliative care training throughout medical school, residency at University of Florida, and then did additional post-professional training at UAB through their Clinical Training Academy in Palliative Care. And so I've still worked very closely with the palliative care program at Southeast Health, which is now run by nurse practitioner Sarah Dalvine. She's been with the program since 2016. She had planned to be here tonight, but unfortunately her new puppy had just been neutered today and he's sick. So she texted me just a little while ago that she wasn't able to make it, unfortunately. But they have a wonderful program there. And so I do talk a little bit at the beginning about palliative care, and then I move a little bit more into end-of-life care planning. So this is kind of a long, wordy slide, but a lot of people ask what is palliative care, and they often confuse it with hospice care. So palliative care is more of a continuum. It's really a specialty dealing with serious illness. So palliative care can be given at any point in time during a medical illness, whether you're undergoing curative treatment or end-of-life care. So hospice is sort of towards the end of that continuum of palliative care. But the goal of palliative care is to treat symptoms from a serious illness and try to prevent excess suffering, but also provide education to family members as you're coping with living life with a serious illness. No, that's all right. That's all right. Here in the Wiregrass area, we have inpatient palliative care at Southeast Health. And then over the past few years, they've also created some home palliative care programs, and those are in conjunction with local home health and hospice groups that have created those programs, taking health care for people at home. So this is just sort of my little diagram I like to show about, what palliative care is and how, all hospice patients are essentially palliative care patients, but not all palliative care patients are at the end of their life. And then comfort care is another type of medical care. You say comfort care, and that's sort of a generalization. When we use that in the medical field or in the hospital, that's usually related to patients that are closer to that dying process, where we're just trying to maximize their comfort as they're leaving this world and moving on to the next. So here's all the things that palliative care can provide. And of course, assistance with advanced directives and end-of-life planning. We do have extra training in that and extra experience in that. I've got experience in that both professionally and in my personal life. My mother was on hospice while I was in medical school, so I have very intimate experience with hospice. And then just recently, we did advanced care planning for my father, who was recently diagnosed with cancer and is undergoing treatments for that. So I've seen it from both ends of the spectrum, both professionally and personally. So Catholicism and palliative care. So you all are preaching to the choir, if you will. I gave a talk at the UAB Palliative Care Summit a few years ago about the challenges and opportunities in providing palliative care in the rural South. And I showed a slide where I kind of overlaid where all the Catholic hospitals are in the United States and how we have less Catholic-run hospital systems here in the South. But out of all hospital systems, according to a 2019 study by the Center to Advance Palliative Care, 91% of Catholic hospitals offer palliative care compared to 72% of hospitals overall. So you all can give yourselves a round of applause for that. That's wonderful. And one of the overlays I did was a map of the U.S. kind of showing that there are more Baptist-run hospitals here in the South, and not to start another religious war or anything, but maybe we need to be talking more to Baptist-run hospitals as well about improving and enhancing their palliative care services. But there's a wonderful publication, A Catholic Death Guide to End-of-Life Decisions. That's from the National Catholic Bioethics Center. Yes, and Father Jim has a copy here. Wonderful, wonderful. Well, you'll see in that packet that it actually has a living will or advanced directive towards the end of that, which would include and encompass, almost everything that you would need for end-of-life care planning too. So I would encourage you to look over that and talk about those things with your family. So it's really a wonderful document, and I do kind of summarize a few points from this document tonight in the presentation. So why do we need to plan ahead? Why is this important? Traditionally these are very difficult things to talk about, especially with our children. I'm a mother as well, and of course my son growing up watching me in the palliative care program, he's not as afraid to talk about death, especially whenever my mother-in-law passed away a few years ago. He was right there with her, holding her hand as she passed away, and hospice was helping us take care of her. But usually these are very difficult topics, and they're sort of considered taboo in our current culture. 150 years ago, people were dying at home. We lived on farms, and death was a part of everyday life. We had cows and things like that we watched from birth to death, and people died at home. We watched our grandparents that were living with us die at home. But since then, more and more people have died in hospitals, and just recently, as of a study that was just put out this past year, and by 2017, that had started to transition back to more people in the United States were dying at home. However, these are pre-COVID statistics as well, so I'm not sure that's the case anymore with the pandemic the last couple years ago. But death has been, for the last several decades, has been really a taboo topic that's not often discussed. And again, Catholics seem to be ahead of the curve because you all are here tonight and having this conference. But death is now taking longer than it was 150 years ago as well, with advancements in medical technology, focusing on other things like focusing on preventative health and preventative care, cancer screenings, things like that. People are living longer, but also from the time of a diagnosis of an advanced cancer or a serious illness like congestive heart failure, people are living longer with those serious illnesses. And so it's really important to prepare for the end of life, but realize that even with a serious illness, you may be living in the terminal phase of a disease much, much longer than you were 100 years ago or even a few decades ago, given advancements in medicine. I always, I say this sometimes at the hospital when I'm talking to patients and their families when we're talking about code status and whether or not they have an advanced directive. And sometimes that's very frightening for people to talk about or even to have their physician mention to them when they're in the hospital, because they're there to get well, they're there to get better and for us to treat them and treat their disease. And they said, why are you asking me about death? Why? I'm here for you to help me, for you to help me get better. Why are you asking me about what I would want, at the end of my life? And I just try to explain and reassure them that we ask everybody this. We ask all of our patients these questions because it's important for us to know. The more we know about their wants and their needs, the more we can handle those things as they come up. But again, none of us are guaranteed the next 5 minutes. I consider myself pretty healthy, but I could get into a car accident when I leave here tonight. So it's really important to talk about these things ahead of time, right? And to ask yourselves, what will my last days look like, and what you would want them to look like, what your family would want them to look like. And again, you know, these two pictures I put here. One is just one that I found on the internet of all the intricacies of an ICU, and Dr. Fillmore can relate to that, seeing the kind of all the wires hooked up to somebody on life support machines and drips going in, and we see that very often at the hospital for critically ill patients. The other picture is actually a picture that I took of family members when we were taking care of my mother-in-law at home on hospice. That was my mother-in-law and father-in-law as she was passing away, and it was a very peaceful, very loving moment that myself and our family will never forget. So often, you know, I also like to say hospice isn't necessarily the gift, the kiss of death. It can be the gift of life in many ways. And so, you know, another reason that we talk about planning ahead is because, you know, sudden cardiac death still happens very frequently, no matter how much preventative care we do, no matter how good our medicines are, no matter how well we're treating congestive heart failure or lung disease or cancer, people still pass away unexpectedly. And what are those statistics? So there have been several studies about talking about resuscitation status and patient preferences when it comes to sudden cardiac death, cardiac arrest, cardiopulmonary arrest. And often when you present some of these statistics to people, they often will kind of rethink, well, maybe that's not what I want, or given my severe medical diagnoses, my severe heart disease, is this something that I would want, you know, to go through, or would I want to allow a natural death if something catastrophic happened? So these statistics are pretty staggering, and those are the most current statistics, even despite changes in what the American Heart Association tells us to do for CPR. You know, every few years it seems like there's new recommendations and different ways for us to resuscitate somebody, different medications or regimens or different modalities we can use to enhance the way we do chest compressions. But regardless, even with immediate CPR, sometimes those things are out of our hands. We do our best, but unfortunately, you can see with these statistics, not many people survive a cardiac arrest. So it's really important to know what you would want if something like that would happen, or if once we do resuscitate somebody, you know, what happens after that. So on TV, you know, you see where somebody has a cardiac arrest and they run in with the machines and they've got the paddles and they shock them, and then all of a sudden they're awake, and, you know, within an hour they're walking around, and, you know, they're just fine. And that's not really how it is in real life. You know, you undergo resuscitation, you're then hooked up to life support machines and an intensive care unit with all of these drips and cords and things running. And sometimes we were fortunate enough that some people survive all of that, and there's definitely amazing success stories. And we really love it when people come in after all of that has happened, whether they've been in the ICU for a week or a month or 2 months, and they come back into the hospital and they see everybody in the ICU. And you know, my aunt is one of those success stories, actually. She had a catastrophic traumatic bleed in her brain. And we didn't think she was going to survive that, and she was in the intensive care unit for several days, actually almost 2 weeks in the hospital, and now she is very independent. She needs a little bit more help than she used to, and she can't drive anymore, but she's still living and enjoying her life. And so there are tremendous success stories to where resuscitation and all of these life support measures and machines and medications do work, but there's also many, many more stories also where those things are not beneficial, and we don't end up having a win, a success. So how do we turn that into something that we can all cope with, that our family members can live with, and how do we make those decisions? That's why we're all here tonight, to kind of talk about those things. Because when you're hooked up to all of these things here, you can't tell us your preferences, you can't talk to us. So what happens though when we don't have advanced care planning? What happens when we're hooked up to life support and all of those things? Or what happens when we develop an illness where we aren't capable of making those decisions, like dementia? What happens then? Well, Mr. Hornsby was just talking about he's seen a lot of these things in his career, family feuds, and that's devastating, right? So, I'm sure if that was your family member there that was critically ill, and I know for a fact, my sister and I, when my mother was on hospice, we joked, we're like, oh, Mom will wake up right now and kill us if we argue about this, or, we often see at the most critical time in someone's life, the most devastating time in a family's life, emotions are high, it's very stressful, and we see too many family feuds. That's quite devastating when that happens. There can be delays in care when we don't have decisions, when we don't know what your preferences are and family members are unsure, that can delay care. The loudest person often ends up making the decision. And whether or not that's a cousin from Colorado that we're waiting to fly in next week, because that happens very frequently as well, or that's a family member, that maybe doesn't even know you that well, but feels like because they were, a secretary at a nursing home for 2 months, that they know better than what maybe closer family members know. But often that's what happens. The loudest person in the room voices their opinions and wants to direct that care. And that might not be the care that you would have chosen for yourself, or that another family member that knows you better would decide on. You may not get the care you would have chosen. So we don't know what care you would have chosen if you don't put it in writing, or if you don't talk to your family members about those things. We don't know what you would have chosen. Guilt burden on the loved ones that end up making the decisions without being informed of your wishes. I see this every day. Every day when we don't know what your wishes are, there are no advanced directives, and a single child is trying to make those decisions for you, right? So I worry, because I have an only child, and I worry about these things already. He's only 14, and I worry that, because we didn't have additional children, that he's going to be this decision maker someday. So my husband and I already have advanced directives and a will and all kinds of things, because the guilt burden is pretty heavy. Just seeing the family members that are kind of trying to figure out, what would you have wanted? What if I make this decision? Is everybody else in the family going to hate me for this decision and resent me for the rest of my life because they disagree with this decision? Those are the things I see family members struggling with as they're trying to make these decisions for their family members without advanced directives. And then uncertainty and moral dilemmas amongst healthcare providers. We want to do what you want. We want to also provide the best care possible, and there are certain decisions that we may medically, recommend or advise for or against, but often there's sometimes not a right or wrong answer to some of these medical questions. It depends on what you would have valued and what you would have wanted for your own life. And so that moral dilemma is very heavy on your nurses and your doctors. All of your providers also struggle with those decisions, worried that we might not, a family member might not be making the same decision that, maybe a week ago or a month ago when we saw this patient in the hospital, they indicated they might not want, or that wouldn't be acceptable to them, but they never put it in writing. And so what guides those decisions? Well, lots of things, way more things than even I have up here. But certainly your experience and your feelings about death, dying, and illness. Some people that have never seen anybody in the intensive care unit or never had experience with somebody on life support machines or on hospice or going through that dying process may not have the experience to know exactly what they would or wouldn't want. And those are the ones that I advise to talk to their practitioners, talk to their physicians, their friends, their family, their priest, to kind of help guide, what those things would look like, what life would be like, with or without certain decisions. Your level of physical independence and mental activity. Physical independence is one of the most devastating things to lose. And often, everyone's worst fear that you're going to lose that physical independence and be dependent upon somebody. And that may change your preferences on your end-of-life planning. Religious views, healthcare literacy. Religious views, on the end-of-life document that you all have also goes in quite a bit of detail about morally obligatory versus morally optional care, as well as the redemptive nature of suffering. And so it does leave some of those things open to, depending on the situation, what you feel is extraordinary care or just ordinary typical care. And I'll go into that a little bit later too. Lots of different things guide these decisions. So now I'll go into just end-of-life care planning in Alabama, because it is a little bit different and there's a little bit different requirements and statutes in each state. And right here in the tri-state area, this may be important for some of you all. I don't know if there's any Florida or Georgia residents here, but I know it's a hospital. We get a lot of Georgia and Florida residents. And so state laws do vary a little bit between those states. So here in Alabama, there is something called a portable do not attempt resuscitation, a DNAR, or you may hear it referred to as a DNR more commonly in the hospital. It's also called an AND, an allowed natural death. A healthcare proxy, also called a healthcare surrogate, or sometimes referred to as a medical power of attorney. Advanced directives, also called a living will, you'll hear it referred to as that. A durable power of attorney. Also in our state, we do have PULSed forms. I included those because they are listed on the ADPH website, the Alabama Department of Public Health website, and I get lots of questions about those. So PULSed initially stood for Physician Orders on Life-Sustaining Treatment, also can be called Provider Orders on Life-Sustaining Treatment, or MOLST, Medical Orders on Life-Sustaining Treatment. Several states have initiated these and have adapted their state code and state laws to include these. They are included on the ADPH website, but they are not widely used in Alabama. And then physician aid in dying and euthanasia, it's illegal in Alabama and not felt to be acceptable by the Catholic Church as well, as you all probably know. So the portable DNR or DNAR, this is just a copy of the form. It's actually a 2-page form. This actually came about in 2016 as an amendment to the Alabama Natural Death Act. It can be utilized across different healthcare facilities. So prior to this, no matter what facility you went to, even if you were transferred from another facility, the DNR from Flowers Hospital wasn't good at Southeast Health, or the DNR form you had at Extendicare wasn't good at Southeast Health, or if we were transferred from another hospital, or let's say we were transferring someone from here to UAB or to another hospital, everywhere you went, your form became invalidated. And you can imagine sometimes when people are very sick, they were able to go over those wishes when they first came to the hospital, and then later on, as they got sicker, they weren't able to wake up and sign a form, right? So when you're really sick, and if somebody didn't have family members available to sign those forms, it often became very difficult if they were transferred from facility to facility. I had a patient one time, and there was actually a case report in one of the medical journals just a couple years ago. It wasn't about my patient, but about another patient very similar to mine that had actually tattooed DNR on his chest. It turns out that's not able to be legally upheld because for all we know, it could have been initials of a past girlfriend, right? So unfortunately, we couldn't find family members, but he had an estranged wife that they had been estranged for 30 years. She lived in Virginia, had another significant other that they had been living together for almost that full 30 years. And although his friends and him were all on a motorcycle trip down to Florida for Bike Week, unfortunately, his friends were very clear that he would not want aggressive measures, life support measures, if he was in a persistent vegetative state. He had had a massive head injury. Unfortunately, we had no decision makers, and he was still legally married to a wife in Virginia, so she tried to make decisions, and it was just a very difficult situation. And so, he actually wasn't transferred to another facility, but had we had to transfer him out, or another patient, I guess, that had filled out a DNR form even previous at a different facility was no longer able to be used. Now, at least, it alleviates a lot of those concerns. So if I'm transferring somebody to a local nursing home or hospice care at home, we're able to transfer this form with them. It can always be rescinded. You can always change your mind. But these can be very, very helpful in those situations. And so we have that now, and almost all hospitals in Alabama have now adopted these. It's also important, especially in a tri-state area like this, that it can be used en route. So we're often sending patients home on hospice care to Florida or to Georgia. It can be used en route from our facility. Once you get to a different facility, unless you're going home on hospice, so it can be used en route for the paramedics, for the EMS. But once you're actually at a different facility in a different state, they may or may not recognize this depending on their state laws. But it has to be signed by a physician, and then there's other areas here. It only has to have two signatures, but it gives you different options for who can sign. So either the patient can sign it, which that's the easiest way if the patient's able to sign it. It can be signed by a provider of the facility or a representative if that patient has an advance directive and they have met criteria to be with a terminal illness or in a persistent vegetative state. A facility representative can sign that. It can then also be signed by a healthcare proxy or a durable power of attorney. And then on the back, there's another area for a healthcare surrogate. There's an addendum or an additional healthcare surrogate form that I'll show you in a minute that has to also be filled out, though, if it's from the healthcare surrogate. So a healthcare proxy or surrogate, so sometimes people like to refer to this as a medical power of attorney. It's a person assigned by the patient. So you assign this person. It can be anybody that you feel knows you well, that can make decisions for you if you're no longer capable of talking to your doctors and making those decisions. A healthcare surrogate is a person designated by Alabama, by the state of Alabama, based on a hierarchy, and I'll go through that in a minute. So this hierarchy does vary from state to state. And then there's a durable power of attorney, usually arranged with a lawyer, but specifically within that paperwork, designating somebody as a durable power of attorney, it should state that that person is authorized for end-of-life healthcare decision-making. We've actually had problems with that in the hospital, not unfrequently, when it doesn't specifically state that, and there's discourse between family members and decision-makers as to whether or not that durable power of attorney can make end-of-life decisions. So how to choose a healthcare proxy. Do you trust them? So you want to choose a healthcare proxy, you want it to be somebody that you trust. Sometimes that's not a family member. Sometimes you may be estranged from your family members for whatever reason. It can be your best friend. I had a patient one time that chose their neighbor because they had been neighbors for almost 50 years. And that person felt like their neighbor knew them the best. So you want it to be somebody that you trust. Ideally, it would be somebody that has some medical knowledge, or at least medical knowledge of your particular medical illnesses. So that's important. Whoever you choose for this, don't hide from them what your medical illnesses are. Even if you don't feel comfortable spreading your medical diagnoses to everybody in your family, at least make sure that your healthcare proxy knows your healthcare situation and knows what decisions that you would make. Will they put my needs and desires before their own? This is a tough one. Because if you know that your loved one, your child, your adult child, or your spouse maybe has different ideals than you do, or different views of end-of-life care, are they going to be making decisions that are important to them, or are they going to be making those decisions that you would have made for yourself? And that's really important. If you know, and I've had patients tell me that before, that they didn't make their spouse the decision maker, they made their adult son or adult daughter or their sister or brother their decision maker because they knew it would be too hard for their spouse to ever let them go. So think about that as well when you're choosing who that healthcare proxy will be. Does your family trust them? This is a big one. Because even while you're maybe not capable to talk to your physicians and make those decisions, all of the other people in your family will be standing by watching all of this happen and watching all of these decisions being made. If they aren't happy with these decisions because they don't trust the decision maker, that's going to cause another family feud, right? So You know, even if it's a new spouse, you know, my father in particular, he has a lovely girlfriend. We love her. They've been together now for about 2 years. But he decided to still make me his healthcare proxy. Not because he didn't feel that she would make appropriate decisions, but he was also worried that there would be other family members that didn't know her very well and didn't trust the decisions that she was making. So, do they have good decision-making skills? That's important too, because that healthcare proxy may be making other decisions that aren't listed in your advance directive. There's a lot of things in medicine that we can do now, procedures, different surgeries, things like that that we will be looking at the healthcare proxy to make decisions about. And you can't include all of those in an advance directive. You can include other things in there though. I mean, you can always, there's usually a spot where you can add additional things, like if you have experience with, you know, other family members that have had, you know, various surgeries, you know, craniectomies during a stroke. That's one that I can remember that I actually had a patient put on their advance directive. They had watched their older sibling, I think it was a brother, had a stroke and ended up having a craniotomy, which is a brain surgery where you move part of the skull. And he felt like that was just a really catastrophic surgery for somebody to go through when they were that sick, and he had written on his paperwork that he never wanted that particular surgery. But it's difficult, it's impossible to put all the medical procedures that could possibly come up. We put a lot of the most common ones often are included as far as, you know, things like artificial nutrition, hydration, things like that are often listed in an advance directive, but we as physicians will be looking to your healthcare proxy to make other decisions from day to day with your medical care when you're not capable of making those decisions. Would you trust them to take care of someone you love, right? So why would you ever make somebody your healthcare proxy if you didn't trust them, right? So I think that's an easy win. And then, are they going to be available? So, for example, when we were making my father's advanced directive, he's in West Virginia still and I'm down here, and that was a difficult decision, knowing that I'm not going to be immediately available. Fortunately, most advanced directives, you can also add a second decision maker, and a lot of them will say, if this person is not available in an emergent situation, who would be your second choice? Or, you know, sometimes your healthcare proxy may be in a car accident with you and not capable to make those decisions. So most advanced directives will also include a secondary person. So here's the Alabama Healthcare Surrogate form, the addendum I mentioned with the portable do not attempt resuscitation form. So in the state of Alabama, the hierarchy for who those decision makers are, if you haven't designated somebody, first would be a judicially appointed guardian. We have those a lot around here, in patients that, you know, are unbefriended elderly. So that's like our elderly population that no longer have any family living around them, no decision makers, not a lot of social support. They often will end up with a judicially appointed guardian. And then after that, it goes from spouse to adult children, 19 or older. It doesn't matter how old the children are, as long as they're over 19, they all have equal say in the state of Alabama. In other states, for example, in Georgia, it's the oldest child. It has the most decision-making capability. If they defer that, then it would go to the second oldest and then the third oldest and what have you. But in Alabama, it's all the adult children equally. Right, Mr. Hornsby? Is that right? And then your adult parents, if they're still living. If you go through this list and you don't have a spouse, you haven't had kids, your parents aren't living, then it goes to siblings as long as they're 19 or older, and it's all of the siblings equally. And then after that, it's sort of the next closest relative. So sometimes it's been cousins. It's been, you know, we haven't been able to find any other family members except a distant cousin or something. So, and then after that, it can go to a hospital ethics committee. So advanced directives, I've put a copy here. They're usually several pages long. This is the one endorsed by the Alabama Hospital Association, and this is usually the one that many hospitals in Alabama will have readily available. However, again, the papers that you all have does include advanced directives at the end of that packet. If it's the same that I got, yeah. So they may vary a little bit differently in their wording, but the overall gist of it is, you know, what type of care you would want if you were in either a permanent vegetative state, or if you were considered terminally ill. And to designate that, it has to be designated by at least 2 physicians that agree that you have a terminal illness, you are terminally ill. So this is what you would create. This is created by you, by the patient, to express those wishes. It's used to tell your doctors in the healthcare facility, your nurses and doctors, what kind of care you would or wouldn't want if you were too sick to make those decisions or tell us those decisions. It's only applicable, again, if you have a terminal illness or persistent vegetative state. You must be 19 years old in the state of Alabama. In other states, it's 18. A lawyer is not required, but you may want to speak to somebody with the expertise like Mr. Hornsby, because they will also be able to guide you through a lot of those decisions that are needed at the end of life. And in the state of Alabama, it requires 2 witnesses. Those witnesses cannot have any financial interest in you, and they cannot be blood relatives. You will find some forms, especially online, if you go searching for an Alabama Advance Directive or for general Advance Directive forms. Some states do require a notary, and so you may find lots of forms that have a section for a notary, but in the state of Alabama, that's not required, just 2 witnesses. Currently, Alabama does not have an Advance Directive registry. Some states do, but that is something that the State Palliative Care Care Committee is trying to work on, trying to get a statewide palliative care or statewide Advance Directive registry. So life prolonging versus comfort-focused care. I go into this just a little bit. So life prolonging. In many situations, certain things that we do at the end of life, really aggressive care, isn't always life prolonging. In fact, some things at the end of life, depending on the diagnosis, are actually life shortening. Some evidence-based studies in our medical journals have shown that certain things at the end of life that you would think would help and prolong someone's life actually take time away from somebody due to the natural dying process and how our body naturally shuts down and often can't accept things like artificial nutrition in certain situations at the end of life. Our body isn't equipped for that, the way that our body shuts down when we have that terminal illness and we're in that dying phase. Other situations, things like artificial nutrition can be very helpful. So that's why I put that in quotations, though, that life prolonging may not always be life prolonging when you have a terminal illness. Sometimes those aggressive measures at the end of life can cause undue burdens and cause suffering without the benefits of things like improving pain or improving independence or mental status. And then other things have, some benefit. It just depends. That's why I mentioned some of the big ones here, like artificial nutrition, dialysis, ventilators. There are definitely some situations where somebody with an advanced illness may benefit from some of these things. So that's why it's really important to talk to your doctor about your particular illness and what the risks and benefits would be of any of those end-of-life procedures.
If you put in there that you did not want life prolonging, but did want comfort-focused care, would that leave the decision up to the medical staff or your proxy?
As far as what comfort-focused care, that's also not a one-size-fits-all. So that depends on the situation and what the person's illness is. For example, somebody that's at the end of life with an advanced lung cancer, that often causes a lot of fluid to build up in the lungs. And so in that case, we would not recommend a lot of hydration at the end of life. And people often say to us, well, won't they get dehydrated? That's not how things happen when you're in that dying process at the end stage of a terminal illness. So it's not a one-size-fits-all. It does leave it up to the skilled practitioner that has experience in comfort care measures to know what the appropriate level of comfort and medications and treatment would be to provide the right amount of comfort for that particular person.
Yeah, that's what I was thinking when you said you didn't want one, but you didn't want the comfort-focused care. It would leave it up to the medical.
That's a great question. And so yeah, that kind of goes over the comfort-focused care, which may not necessarily treat the disease itself, but will try to provide the best level of comfort no matter what your terminal illness is, whether you're having difficulty breathing, a lot of pain, confusion, hallucinations, other things that we see at the end of life. It's different for everybody, that journey. And so there may be different treatments for those things. So morally obligatory versus morally optional. And Father Jim is probably the better expert to talk about these things, but I did want to touch on them because it is in your packet there as well, and what the Catholic Church says as to these things. So, and I can kind of give you the medical advice of what some of these things may be and how they would apply medically. So morally obligatory, ordinary measures to prolong life. So one is held to use only ordinary means according to the circumstances. And that means that do not involve any grave burden for oneself or another. So following your Catholic faith, although I'm not a Catholic professional, but I would assume that some of these things would be just our general normal care to prolong your life, whether it be, having rectal bleeding and we may do a colonoscopy. In some situations, somebody may not be well enough or healthy enough to undergo that procedure. So again, that's going to be different for everybody as to what would be normal care to prolong someone's life. If we can do something that doesn't have excess burdens and may provide more life or more quality of life, that might be something that you should consider based on your Catholic faith. Morally optional, extraordinary measures to prolong life, defined as medical procedure that carries with it little hope of benefit, is unduly burdensome, and that you're free to refuse those treatments when it's of dubious benefit or when its burdens are significant. And so some of those things you're going to have to rely on your physician to talk to you about and see what's the benefit of these procedures. Just because we have all this medical technology and all of these procedures and skilled surgeons and specialists that can do lots of things to somebody, is that really going to benefit you? Is that going to provide you more life? And those are really important questions to ask because we have lots of things in medical technology. Every day they're coming out with some new procedure to save somebody's life and to help people. But there comes a certain point, and in certain situations, those things are not beneficial to people. So just because we can do a medical procedure to somebody doesn't mean we always should. And then just to hit on the post forms again, these are not formally addressed in the Alabama Code of Law, including the Alabama Natural Death Act. I just bring them up because I do get questions about these at the hospital, and the forms vary widely, but overall in our state right now, they're not widely used. So where to start? So now you have all this information, where do you even start with all of this? Well, you're here right now, so you've already started, but I would definitely take all of this information that you've gotten tonight and talk to your providers, talk to your physician, your nurse practitioner, your primary care provider, your specialist. Talk to them really in depth about what your prognosis is, what's to expect with this diagnosis that you've just been given. Have you just been told that you have congestive heart failure? What does that mean for you, given all the new medications we have to treat congestive heart failure nowadays? What does that mean? And have that honest conversation. We as physicians, we sometimes get caught up talking about the medications and the treatments and the numbers on the computer. This was your potassium level, this is your creatinine. We get caught up on those things when we're talking to somebody in our brief little session where we get to actually talk to you and not type on a computer. So stop them for a minute and just say, hey, give it to me real. Tell me really, what is this going to be like for me? What does this diagnosis mean for me? Am I going to need dialysis? What does that mean? How is my body going to tolerate dialysis? And that's very different based on your diagnosis. Not everybody tolerates dialysis well. And ask them for the real statistics. We have statistics on everything nowadays. There's 1 billion medical journals with evidence-based studies in them that can give you some idea, give your practitioners, your physicians, an idea of what to expect, right? So ask them to be truthful with you. Sometimes when people ask me, well, what does this mean? Or, how long have I got, doc? Well, nobody can predict that. But I do often ask them, I'm like, well, do you want me to be truthful with you? Do you want me to be honest? Or do you want me to sugarcoat it? And anytime I say that to somebody, they're, well, I want you to tell me the truth. I want you to be honest, right? So those are the hard things because we often like to sugarcoat things as a physician. We like to be the saviors. We like to fix people and to say, yes, I cured you, or yes, that's why we go into medicine. We go into medicine because we want to help people. And sometimes there's just things that we can't fix, that we can't help. And so it's hard for us to talk about that. So you may have to really pin your doctor down and say, listen, I need you to be truthful with me. I need to know what to expect. I need to tell my family what to expect. And, and let them give you their best shot at, okay, this is really what to expect based on my experience and based on what the evidence tells us. Here's what to expect with this disease. You can always ask to speak with the palliative care service if you have one of those available. There are outpatient palliative care services at most cancer centers, including university centers like UAB, Emory. We don't have an outpatient palliative care service here. We do have home palliative care and, like I mentioned, palliative care at Southeast. But they're often the experts on prognosis. We have all of those figures in our head usually without having to go look them up. And there's also performance scores, other things that are evidence-based to tell us what to expect based on frailty and level of independence and things like that. Discuss what's important to you. Discuss the goals of your care and your treatment plans with your doctors so you know what to expect. What if this first round of chemo doesn't work, doc? What then? So talk about all those things, and then review it with your priest or other people that you trust. Review it with them. Review it with maybe friends or family members that have dealt with similar illnesses. You should be periodically reviewing and updating these advanced directives as well. Like, for example, I just mentioned we did my father's. He had an old advanced directive from 2015 when my stepmother was living, and her name was still on it. And so he hadn't updated it since then. So just remember to update these things periodically. Update them based on new diagnoses, because that may change some of your decisions. And then make sure you make copies for family, your healthcare proxy, your physicians, and your hospital. So lots of copies. And I get that a lot too when I ask people, well, do you have a living will? Do you have an advanced directive? They're like, yeah. And I'm like, okay, do you want to tell me what it says, or do you have a copy of that I could put on file? And they're like, oh, it's in a safe at home. Okay, can anybody get into that safe? Does anybody know what's on that advanced directive? So sometimes people are hesitant to kind of provide copies of that when they go into the hospital or when you get a new physician. Make sure everybody has a copy of that. It does you no good if it's sitting at a safe at home that nobody can get into. So just make sure everybody has a copy of that. And then there's some resources. There's a book, Hard Choices for Loving People. It's by Hank Dunn. It's a nationally used book across the palliative care services everywhere. Hank Dunn was a chaplain. He was a hospice chaplain for many years. I got to meet him at a national palliative care conference. But he's now on the 6th edition of his book. And it's a wonderful book because it also provides a lot of end-of-life medical decisions in lay terms. So it's not a bunch of medical jargon, like I don't know what he's talking about here, I can't even pronounce this word. So it gives you a lot of medical information that's backed by evidence-based medicine. So it cites studies and resources for things that are provided in this book. And it's a very short book, it's an easy read, but it's been very helpful to many families that I've had at the hospital on our palliative care service. And so it uses lay terms, but it also doesn't persuade you one way or the other. It just provides the evidence. So if you're worried about asking some of those questions, or you're not even sure what questions to ask, it's a great book. I brought 3 copies for Father Jim to have, so those will be available for you all in case you need them. And then Being Mortal by Atul Gawande. It came out a few years ago. He was a surgeon at Harvard, and his father developed cancer. And so it was his view as both a physician and living with a father, a family member that had a terminal illness, and kind of seeing both ends of that spectrum, and his experience with that. So those are some great resources for you all. And then Mr. Hornsby and I will be available for questions too. Does anybody have any questions right now? I'm sorry? Too many? Well, I'm around. You can come up and talk to me if you don't want to stand in front of everybody. I'll be around for a while too. What's that? Well, we can at least get started tonight if I can answer any questions tonight. I'll stay around for a little while.
For medical proxy, down the hierarchy, says adult children treated equally. Does that mean all of your children can be put down without a hierarchy?
Yeah, so you can do that. If you're wanting to just designate a healthcare proxy, you can list all of your adult children and they all have equal say. Now, if you have a lot of adult children, sometimes it's beneficial to just designate 1 or 2 of them, just because they may all have different opinions. So if you're not sure that they would all be on the same page, having kind of, too many cooks in the kitchen, if you will, is sometimes difficult. And so you may want to choose just a couple of your adult children, but frequently I've had patients that put all of their adult children on there as their healthcare proxy, and they all have equal say. Without listing who you want that to be, it would be when you're going through that hierarchy, and when us as physicians are trying to track down those family members to make those decisions, we're obligated to, when we get to that point, if there's no guardian, spouse, and then we get to the adult children, if there's nothing in writing for which adult child you want to make those decisions, we have to discuss those decisions with all the adult children, and they all have to agree on what that decision is going to be.
Appreciate you. And we'll let Ernie come up and let you go. You want Ernie to go next? I want to make one comment about that last author up there, Atul Gawande. He's a surgeon at Harvard, I believe, is where he was, and he's a brilliant guy. And in relation to what Dr. Christie said, she said that they have lots of things, and surgeons can do a lot of stuff. And he is quoted as saying, the operation to do is the one that we're not going to do. In other words, if you have pancreatic cancer that's spread all over your body, there's no reason to do a Whipple procedure on it, because it's not going to do any good. It's just going to make you feel bad for however long you have left. So it was a great comment by a great surgeon. Don't have the operation that you don't need. So that was him. We've made good progress on this particular topic in the state. The Alabama Public Health Department, the Alabama Hospital Association, and the Alabama Medical Association have pretty much come together on all of the things that Dr. Johnson has presented here tonight. And that's made it a lot easier for practitioners to be able to do it. And I'll just say one more comment about that is, she said it, and the first thing to do when you go out of this room with all this knowledge is talk to your primary care physician, whoever that is, and go over the needs. A lot of people, when they go away from these talks, didn't focus on that, but that's what's the most important is you've got to have, I think Lila just took her advanced directive to a new practitioner that we go to and ask for a copy. So that was the first thing through the door, and they've got a copy of that. So please, always, we've got lots of doctors in the parish. If they're happen to be your doctor, we'll sit down and visit with them about this issue. Ernie, I know Ernie had a few comments about healthcare directives and the power of attorneys and those things. Thank you.
When Dr. Fillmore called me, and then Eric called me, although you called me first, and then Father calls me, and just stops me outside of Mass and says, we need you to appear at this conference and answer questions if there are any that are asked. So that's primarily what I'm going to do. There are a couple of things, though, that I do want to point out. Although we're primarily here to talk about advanced healthcare directives, and that's what Dr. Johnson, that was a terrific presentation.
Yes,
You
very,
did.
very.
That answers a lot of questions that you may have, and frankly, that I had from that side.